I am ready when you guys are.
Okay.
So, first off, can you just give me the background of like when you started learning about trauma-informed care, that type of thing?
Sure. My first experience with trauma-informed care was actually when I was in practice for about 5 years at Gunderson. And so really my entire training from medical school to residency in the first 5 years, it was really kind of a concept that was really unknown to me. So I was exposed to it through our Department of Pediatrics, kind of in an initiative to roll out for providers. And so that was really my first experience about 5 years into practice. So about 7 years ago.
Okay. Can you describe how you thought about providing medical care before learning about trauma-informed care?
Sure. I imagine I'm like a lot of providers and physicians at Gunderson, where again, sort of most of my training in the early formative years of my practice, I actually did not have the trauma-informed care lens and philosophy to work with. And now that I do have that, I'm able to look back and reflect on how things are different or were different back then. And I think the biggest difference is just how siloed my thinking was medically. And what I mean by that is, for example, if I have a patient with chronic abdominal pain, prior to being trauma-informed, I think I had two separate tracks that I would look at that problem. I would look at the medical causes first. I had a list of organ systems that you would think about as far as causing the pain, and then diagnoses related to those organ systems. And I kind of looked at that as sort of a separate category from the other track that I would look at, which would be more of the sort of trauma history, adverse childhood experiences, mental health causes of sort of pain, and also how the sort of the pain and the trauma history could interrelate with actual medical illness as well. So I think my approach was much more siloed. And I think I actually sort of missed out on kind of how interwoven those two actually are. How mental health issues and trauma history, adverse childhood experiences can actually not only lead to physical symptoms, but also change how a person may interpret those symptoms, and also change their ability to, number one, seek help for them, and then also the ability to sort of follow through on any sort of medical plan. So my view is much more siloed, much more separate, and I think that's been sort of probably the biggest difference now that I realize what trauma-informed care is and how to sort of mesh and weave those two together.
Okay. You kind of answered this, but so how did things change then? Like, how did you figure out how to weave those two different tracks together?
Yeah, it's when I first went through the trauma-informed care program, I think it really hit home very quickly. It's a new concept, but a very easy concept for somebody in primary care to really sort of understand, because it's what you deal with almost on a daily basis. So it helped me to sort of interweave those two different siloed areas and how I would approach patients. So again, the example of chronic abdominal pain, so long-term abdominal symptoms. I used to have a track where basically would go through the list of medical causes, evaluate that with a history, physical exam, imaging studies and labs as necessary, and only at the very end, if all those came back normal, if no cause was determined, would I start to entertain the possibility of trauma history, of adverse experiences when a child was young that haven't been dealt with appropriately, or also mental illness, including anxiety and depression, and how those could actually be a cause of the pain. So when I first heard the framework, what I did was I didn't change that. I think a physician's job always will be to rule out medical causes and make sure that isn't the cause of the symptoms. But what it did is it helped me realize, number one, how common trauma really is. It's amazing how many of our patients are affected by trauma or adverse childhood experiences. And so what I've done is I've kept the same list of medical causes, but I've kind of increased the frequency and how early I ask about those other components. So it's allowed me early on in the evaluation to bring up difficult subjects such as anxiety, depression, but then also to try and dive into trauma history or adverse childhood experiences, and letting the families know that this is something we know can cause medical pain and problems. And so bringing that discussion up earlier has probably been one of the biggest changes. So I still do the same evaluation, but it's more interwoven, and I actually try and address the trauma and adverse experiences earlier in the process versus later. Because to be a good physician, you have to approach the common things, what's happened most common. And unfortunately, trauma is so common in our populations across the board that people in primary care, this will be a significant component of people who are presenting with physical complaints, whether it be headaches or long-term belly pain. So it's helped me to adjust how early in the process I start that evaluation, how early in the process I openly ask families about it. And I think that's really helped me bypass a lot of unnecessary testing, and it's helped me get to the sort of the bottom and the root cause of the issue sort of initially. And even if the trauma isn't the cause of the symptoms, it a lot of times will affect the patient's ability to follow through on recommendations. So it's opened up my eyes to the fact that sort of following medical advice can be challenging financially and just logistically. So it's helped me to kind of open that discussion early. So even if there is a medical cause that needs to be dealt with, it helps me look into barriers that the patient might run into in order to implement the plan that we come up with.
Okay.
Yeah.
I think people, just looking at it at first glance, will think like, well, why hasn't this been happening for longer?
Mm-hmm.
But this is more of just things have come to light and we need to really focus on this perspective change then? Is that right?
Mm-hmm. Yeah, it's an interesting issue. It is a newer concept, I think, for physicians to look into this. I think younger physicians earlier in their training, this may be a component of how they train, but for myself, kind of being in practice for 12 years, it just wasn't a part of of how we sort of approach medicine. It'd be a mistake to say it was completely separate. It was always been meshed, but how we sort of bring that together and how interwoven it is has definitely changed. I think some of it in pediatrics anyway, and child health, is actually a function of how healthy children have become. So I try and let students and residents know that actually this is a positive. This is a positive. We have immunizations that keep people healthy. We have antibiotics that sort of stop kids from having to go into the hospital for serious infections. So as children become healthier, we're able to shift our focus to other things. And a lot of pediatricians and people who take care of children call these the new morbidities, so adverse childhood experiences and trauma, social challenges, and the social determinants of health. So it's partly that people are healthier and we're able to focus, but it's also partly just when you're in practice and you're taking care of people, you realize just how common this is and how really the primary driver of people's quality of life and their overall health care is dictated not necessarily by just their cholesterol level, their blood pressure, but also their housing situation. There's how they feel safety-wise at home and sort of what resources they have. So it's part of an expanding view of healthcare. But it's also somewhat of a positive that people are healthier and physicians are able to focus on it.
Okay. Can you talk to me about positive outcomes that you've seen since you started really understanding and practicing trauma-informed care?
Yeah, I think it's when you first get orientated with trauma-informed care, it seems it's really enlightening, and I think from that point on, you will look at almost everything you do in your practice in a slightly different way. You're still a physician, your job is still to diagnose and treat, but how you get to that point is just changed, and it's really permanently changed. For example, it affects how we take histories. For example, the words we use in clinic can be very important for all patients, but definitely patients who are experiencing or have experienced trauma or may have social challenges at home. So a classic example would be if somebody's taking a long-term medication for their asthma. Oftentimes earlier on in my practice, my phrase would be, "You're taking the medicine as we prescribe daily, aren't you?" And kind of left it like that. Kind of, as you can tell, that would be very hard for a patient to open up and say that either they couldn't afford the medication or they lost the medication or it's at somebody else's house. So it just, but now through a trauma-informed lens, I've changed even just my phrasing and how I actually ask those questions. So I actually usually start that question with, life can be crazy and chaotic. It can be difficult. These medicines can be expensive. we find that a lot of people have a hard time either picking up the medicine or staying on the medicine. Have you found that to be true? And that's a completely different question. It just opens things up. So from a physician standpoint, that gives you more accurate information from the patients. But also from a patient satisfaction standpoint, I think people really sort of like that humility and the idea that their physicians and providers are aware that life can be a challenge and it can be a struggle. And sometimes people are running into barriers that we don't even really know. So my practice has changed from a history-taking standpoint. So that's one specific example. But as you work your way through the day, the language you use, how you ask questions, how you try and get to the answers is just slightly changed. You're getting the same information, hopefully better information, but how you word it can be absolutely critical.
Do you want to talk about the example that you had kind of mentioned?
Sure. Another example of sort of how my practice has changed is just on the physical exam. The physical exam, as a physician, you do it every single day. You sort of almost, you do it so often, you don't think about it very much, and it's hard to put yourself in the patient's shoes that it can be sort of a vulnerable experience. It can be sort of a stressful experience. And when I first was sort of heard of trauma-informed care and went through it, I actually sort of had one of my first patients with a known history of trauma. He was a 12-year-old, and since our last well-child checkup, he had sort of went through a trauma experience. So I was very nervous going into the exam, knowing that we were going to have to do something that was sort of invasive and potentially could have brought back some pretty terrible memories for him. And it was a really humbling experience because I didn't know how to approach it. It's something you don't learn in training. And I just had to be very open with the family to say that I was nervous for the exam portion because I didn't want to re-trigger any sort of past events for him, and that it was stressful. So it ended up being a very good experience because we were able to talk it through, the exam part. But as I went back to my office, I thought to myself, well, I knew he was exposed to trauma. We know trauma is common. How many times have I done an exam on somebody who maybe had a trauma history that I never knew of? So it definitely changed how I approach the physical exam. I almost do universal precautions for trauma now, meaning that as you approach a sensitive part of the examination, if you don't know the family's trauma history, the patient's trauma history, treating it as such. So making sure you're very clear on what the exam is and why it's necessary. Things like asking for consent. Is it okay if we do this? To make sure that they're on board. And then also get their input, how it would be most comfortable for them. Some people would like their family in the room, family out of the room, a nurse present, nurse not present. So there's a wide variety of ways where we can sort of actually make it more comfortable for people. Because really there's so much trauma in our sort of population, but a lot of times we don't know that it's there. So that one episode where I knew it was there really made me change how I approach the physical exam. And it was like a light bulb going off that we need to be sensitive to those situations. Because one thing trauma-informed care teaches us is, number one, that trauma is common. But number two, people who've experienced trauma tend to be less likely to seek out medical attention. For exactly that reason. It can be a very difficult experience. It can bring back bad memories. So as a healthcare system, if we're more open to that, more sensitive to that, hopefully we'll get more people to come into our walls and get the necessary medical care that they need, knowing that those sort of exams will be sensitive and that we're aware of that, even if they haven't fully disclosed their trauma history. And so I think it was a really eye-opening experience. So it's changed how I take my histories, how I do my exams, and those are two more concrete examples. But as I work my way through the day, I'm always thinking about that trauma-informed lens. It's not one answer, one way to approach a history and exam. It's a mindset, it's a philosophy, it's a way to sort of adjust how we interact with patients on a regular basis.
So you talk about kind of that light bulb moment. It's so easy in what we're doing to kind of just do what we've always done.
Mm-hmm.
How would you convince your colleagues to really take a close look at trauma-informed care and putting it into practice?
Yeah, I think it's a good thing because there's a lot of things that physicians and providers are asked to do, and there's a lot of things that physicians and providers are sort of either told to do or sort of expected to change. And but trauma-informed is one of those things that when people hear what it actually entails, I think it really fits with what physicians and providers want and need in their own practices. Everybody wants to be successful. Everybody wants to be effective in what they do. And the trauma-informed lens isn't sort of one additional thing that they need to do. It actually makes them sort of more effective. It makes you more effective as a provider. It has you ask questions in the history that will give you more accurate information. It sort of helps families be comfortable around you, including the examination and other components, to make them more likely to come back to see you. One of the big negatives of primary care is when you have a plan and people aren't able to come back in or don't come back in. So creating an environment that's sort of safe, inviting, and trauma-informed will sort of hopefully increase the patients who come back for follow-up. So it really sort of makes us more effective as physicians, and I think that's a very important thing. And I think all of us as providers, we want to be the person who understands what's going on, who knows the reason why the patient is actually in front of us. And I think by sort of having a trauma-informed care lens, you identify one of the more common causes and one of the more common sort of modifying factors, which is a trauma history and the mental health component that can lead into it. And I think when people have been out in practice for a while, they start to realize that these sort of obscure esoteric medical causes aren't as common as anxiety, depression, food insecurity, trauma history. So as you've been out for a while, you start to realize that you can sort of adjust how you think about it. So I think it improves our efficacy as providers, which is good. But I think it also helps physician burnout, which is a huge issue. Physician burnout it's very, very easy to become cynical when you're a physician. Sometimes it feels like the people who need your help the most are sometimes the least receptive to it. And a lot of that is sort of can be changed and adjusted by looking at things through a trauma-informed lens, how you approach families, how you ask them questions, do the exams, set up your practice, can make them more likely to see you as a trusted ally and not somebody that needs to be feared or sort of somebody that's going to look down on them or judge them. So it actually increases that longitudinal relationship, which is absolutely critical to keep physicians engaged and happy. So I think it helps the two biggest things that we really look for. One is just being an effective physician where your families value what you do, but then also it just makes your job more satisfying because it helps you understand some of the behaviors that if you don't understand the causes for them can be very frustrating. So I think it helps both of those major things. So I hope other physicians would be open to it because I certainly feel like both of those parameters have been affected in my own practice since I've had that trauma-informed philosophy and understand its values and what it's trying to do.
How does it make you feel personally to know that your practice is more effective now?
Yeah, I think it's a great feeling. I think it's a great feeling to know that you're effective in what you do. And the more we study about burnout and satisfaction in any job, it seems like that ability to sort of have mastery over what you do is an absolutely critical thing. It's a Gunderson initiative to sort of give people that intrinsic motivation, and mastery is a part of that. Just being competent and comfortable handling those situations. I think when you deal with difficulties in clinic and you don't feel like you have the right framework or the tools or the skills to deal with that, I think it erodes your enjoyment of your job, and also it can make you very cynical and kind of lead to you to be not very happy in your position. So it makes me feel very good to sort of have those skills and be able to work on those skills and also realize that it's something that can be taught and can be learned. And even fairly easily too. And if you sort of enjoy it and you're enthusiastic about it, you can actually sort of change your own sort of lens and actually improve your own practice, which is, again, that's a autonomy piece, which is very, very important. So it feels great. It feels really great. Yeah.
Anything else you can think of to ask or anything to cover? I think we got a lot of good stuff. I don't know how I'm going to cut half of this out.
Yeah.
Okay.
Fantastic.
Anything you can think of?
No, I think that was basically it. I think we
great.
talked about everything. So yeah, I think we got everything across that we wanted
You
to.
mentioned colleagues. Any thoughts on a healthcare system in general, or the bigger health? We're actually one of the sectors, one of the last sectors to really fully embrace the trauma-informed care. The medical community's coming around to it, but just on that bigger scale for healthcare and the impact. And I guess you probably want to, if you answer to him.
Oh, sure.
But
So the community-wide, or the kind of the healthcare sector being involved, it sounds like?
Health, trauma-informed care and healthcare in general as a field, the whole field of healthcare.
Yeah, I think having trauma-informed care being adopted by healthcare has been it's been a huge advance, and I think it's been very critical. And the reason for that is I think we're judged as a health system, not just in your own individual practice, but every experience a patient has within your healthcare facility. It doesn't matter if it's a regional clinic, if it's in the emergency room, urgent care, or even on the telephone, can sometimes sort of turn people off to the point where they'd be sort of skeptical of the healthcare system in general. And so having the healthcare community as a whole embrace it is a great thing. You can't do this on an island. You can't have one provider who wants to be trauma informed when nobody else does. So it's a community-wide effort. We have to have it sort of throughout Gunderson Health and throughout our regions because as people interface with our clinics in various areas, they take each experience as a, sort of a component of us as a whole. And so having everybody on board is really welcoming. It's a great thing that people are showing the desire to look into this pathway too. It has a lot of benefits for the individual provider, which we had talked about, but if we do it as a system, the effects would just be magnified because then people would look at the healthcare system as something that could be trusted, something that can be valued, and really is a place that they can go with information that sometimes isn't easy to talk about. And it'll just open the doors to people who previously may have sort of shied away from healthcare sort of in general. It'll help us sort of change healthcare disparities and hopefully get more people to sort of look at us as a valuable resource for them. So doing it sort of health system wide is a great thing.
Okay.
Yeah.
I think that's all we got.
Okay, sounds good. All right, thank you. Yeah, sounds good. Well, good we got it done. Yeah, thanks. That was great.
As part of